Hi everybody, welcome back on this Wednesday and weekly webinar. We're pretty much into the last part of the All on 4 series. As I've said before, you will be able to, anybody who hasn't watched the other 3 or any of the other seminars, including, introducing implants into your practice, the 4 webinar sort of introduction and a number of the other webinars in between. We are in the process of getting everything uploaded so you have access to everything. But today we're going to be finishing off with the last part of the All on 4. And I want to, first of all, I've had a couple of requests. I will at the end, said, like, I haven't had time for questions, so I will be asking some. If anybody has any questions at the end, my apologies if I haven't given enough time for that. I hadn't seen any questions pop up, so therefore I thought there wasn't anything that people were particularly wanting to talk about, but we will go through that today. I want to start with a bit of occlusion. I've had a couple of inquiries about wanting to talk a little bit more about occlusion generally, whether you're using general dentistry, you're doing aesthetic dentistry, which I also used to teach, or implants and full mouth rehabilitation in this case. There are a few things that are slightly different, but basic principles are important. I'm going to get right into it so that we can go through. This is the last of the webinars for a little while. So I implore you to sort of get involved, come to the boot camp. I think we've opened up some extra spaces for that because there has been good interest in it. So we just, if you want to get on board, please inquire ASAP before it closes out completely. I think it's coming to an end, the actual signing up for it. So we'll have a chat about that later, but I'll go through again for people who haven't. Please excuse me for people that have been watching seminars. I'm just going to go over some of the basics again of what's available. And for new people, you'll be able to see what we're doing at the moment. I'm just going to share my screen. We'll get into it. Hopefully, we won't have any problems with Zoom today. Okay. So Bootcamp 2022's 2 attendees for $595. What that really means is that it's $595 per person, but if you bring a buddy, if you bring a friend, it's the same price, so you can share that cost between you. So, it's literally under $300 for a 2-day event. I don't know of any other event in Sydney or Australia going on, which gives you 2 days worth of information, in-depth information for that price. And also you'll get 12 hours CPD. So, it's not a bad way to start your introduction into implants, and the bootcamp will cover everything that we've covered in sort of general terms in our introduction into implants. If you want to introduce implants into your practice, if you are placing implants and you want to revise and go over what you should be doing, medical, legally, consent-wise and otherwise, this is a great place to start. We will be taking cases, we'll be applying all the principles that I've talked about, and once the webinars are up and you have access to them, you can watch them beforehand. That's a good idea, but we will be going everything in a concise way, in the way that we are actually treating a patient. So we'll take cases and go through them. There'll be some theory again, some condensed theory, but we will take a case and we'll apply all those theories from start to finish and have a few different cases, so that you have some diversity and know what to do in those cases, how to assess the cases, how to have informed consent, how to write notes that are compliant with opera guidelines, but also how to plan the case, and then how to execute the case and restore the case also. I will be doing some live demonstration, so you'll be able to see all the principles that we'll be talking about being applied in place. If you're interested, please apply at hello@drbobbychhoker.com.au, the email there, or you can give us a ring, 0280709010. We'll be happy to talk to you. If you do ring, please ask to speak to Millie, who is the course coordinator, and she will be able to tell you what's available, what you can do, and how to sign up for the course. We're also, as I said before, we're trying to develop our website for dentists and try to expand on that. We rely, rather than heavy marketing, on having a community. So please like and share our Facebook and Instagram. It really does help us, and it allows us to create these events for this sort of budgeted price ongoing. So it just really helps everybody else and you. I will start the webinar without further ado. As I said, I've been asked a few questions about talking about occlusion. We'll go back to a bit of the occlusion part within this, but I will ad-lib over what is there to tell you what I tend to do and what are some of the basic principles. So the occlusive consideration, this is if a patient has maxillary dentures, but we're going to go into why if they don't. So here they basically assessing for balanced lingualized occlusion. And what that basically means is that, the thing with the implants is that they're fine with tensile and compressive forces. They're not very good with shear forces. So that's basically what you don't want to have on them. And quite often, if we're placing implants, for example, if I'm placing upper restorations on implants, I want to make sure that the buccal cusp of these restorations is quite shallow in its guidance and not steep. So there isn't a massive force in guiding down the buccal cusp with the lower teeth and getting out. You want them to get out quickly, and that's your shallow guidance. That's in lateral excursions, but you need to apply the same to the anterior teeth as well. So you also, the reason they ask for a check for existing denture for excessive wear, because you can see some of those habits that are involved in that. And they talk about modifying the teeth and ensure that dental maintains a proper vertical dimension, the VDO. There's also a lot of controversy about this as well, saying that you can't increase it above 3 millimeters, etc. Now, that's not true. You need to be careful how much you increase it, because what you're doing is you're taking a lot of people, if you're increasing the VDO, that are conditioned to a particular vertical dimension. So what happens is strut muscles and the masseters are conditioned to that. So when you actually increase that VDO, those muscles have to have time to extend and adapt to that. They're not fixed, they are dynamic. And that's important. And patients can actually accommodate, larger increases in VDO, but sometimes you have to go through graded steps. I'll go into the other bit with the denture aesthetics. I'm not going to go too much into that, because most people, you don't often get people upper and lower dentures. I do, because people don't want to wear dentures anymore, so they want to go into fixed prosthesis. But if I had to put down the list of things that you should be looking at occlusively, whether you're doing general dentistry, crown and bridge, implant dentistry, aesthetic dentistry, whatever it may be, this is the mechanics of dentistry. And the unusual and the ironic thing is that it's not taught at a very high level at the undergraduate level, and postgraduately there aren't really a lot of courses unless you sign up some big course, and an element of it is occlusion. There are a few things. First and foremost, you want to make sure that you have anterior holding stops. And what that means is that the lower incisor teeth stop very firmly in the direct space onto the cingulum of the tooth above. And you want to almost have it as a ledge so that they have a definite point of contact. What you don't want is a slope. So that's the first thing. The second thing you need to do is make sure that the anterior guidance is in harmony with the envelope of function. Now that's like, what the hell does that mean? What does that mean? Okay. So what you want to make sure that is that their movements anteriorly are in harmony with their jaw joints. So if they're having to actually, they have a block or they're having to strain, they're not in harmony. And one of the best ways, how do you measure an envelope function? Do you have to go and get some special equipment? No. The best way to do this for me is, rather than trying to get into some really detailed ways, you want to try to keep it simple. As I said, you want the guidance to be shallow. So you don't want people to be deep, like a class 2, div 2 type of occlusion, and having to drag their jaw all the way down and out. Okay. What you want to do is have sort of like a class 1 occlusion, but shallowed out, so that people can escape easily. And that means that there aren't any additional forces, and it allows their jaw to move out and be free. The problems that occur with occlusion is the fact that it depends on where you're restoring to, whether you're restoring it to intercuspal position, ICP, or centric relation. My personal view, and this is my personal view, having been through sort of camps of Dawson Institute in Florida and Pankey, is the fact that I think that you want to take it back to its physiological condition and its harmony. So usually there's no problems with jaw position. It doesn't have to move out of place to get the teeth to meet together. That's the problem. So what happens is that your jaw is in the right place, everything's fine, then the teeth come off. And the teeth are not in the right position in relation to the jaw sitting in its right position. So your jaw has to come out of its socket, one side or the other, or both, or an excursion that does one and then the other for the teeth to meet. So you have to go from centric relation to ICP. And what you want to do is have both of those in harmony. The important part of this is for you to be able to put a patient into centric relation confidently and consistently, so that you can know where centric relation is and see whether the teeth are in that position. The advantage that you have with full mouth rehabilitation is the fact that you can then move the teeth around wherever you want. Whereas if you have somebody with a full set of teeth that don't need removing or anything else, you have a few options. If you find that there's mild discrepancies, you can use equilibration. So you can adjust the enamel and take gentle bits off so that they come into central relation, coincides with ICP. And the best way of assessing this in the past used to be to get study models, and you grind the study models, when I learned way back in the day. And you'd see, after grinding the models and getting the two to coincide on an articulator, how much tissue you've taken away. And if it's excessive, then that wasn't an option. The most conservative option was to move the tooth into that position. So it's basically using orthodontics. And if they had a heavily broken down mouth, which is predominantly what I used to do, was full mouth rehabilitations in crown and bridge form rather than implant, was to basically create a diagnostic that allowed them to do that. Put them into diagnostic in the form of, if we were, usually these cases were full mouth crowns or full mouth onlays. And if they weren't, we could use composite to do that. And then basically grind that composite or the temporary crown so that we got the two to coincide. Once we did, that was a template for us to then restore that in the permanent. With implants, then full mouth rehabilitations, we have the liberty of actually coinciding the two. And the best way for you to get patients into centric relation in a simple way is, I implore you to try and look up and find out, and if some of you don't know how to do this, you can contact me and I'm happy for you to come in and I'll show you how. Is one, you need to get the patient-centric relation, and the best way to do that is deprogramming, whether you're using an anterior jig, a Lucia jig, or a Cois appliance, or whatever it may be. Everybody likes to put their name to it because they want a legacy. And what it does is put the jaw back into the right place. The other way of doing it is by manual manipulation, which is immediate. I can talk to you about that. But once you've got it there, you've got to record it. And recording it is very important. And in the old way, we had a very wedge type, special type of very brittle wax that we used to use. But now with the advent of digital technology, you can actually get them there and record that digitally. So if you take scans of the upper and lower, when you do your occlusion, rather than just getting their teeth to meet, put them into centric relation and record that position, because that will be your restorative position. The other parts that you need to have are two very important parts, is to make sure that there are no interferences on the working and non-working side. So you put them into lateral excursion, make sure there aren't any interferences. And if there are, again, to see how much you would need to reduce to actually remove that interference. It's usually the first or penultimate molars that you need to adjust to allow that. And the basic rule of thumb is, if you're getting sort of locking at the front, a millimeter change at the back produces 3 millimeters at the front. And I could go on about occlusion all day. It used to be sort of my forte, and It's an absolutely huge subject, but I'm trying to condense it into what you can take away and use immediately. And if you have any questions on that going further, please contact me and I can elaborate on them and I can tell you how to sort of be safe in doing that. Because if the problem with, as I said, the irony of it is that occlusion isn't taught at the level, and occlusion is the mechanics. So when you went to medical school and, you know, you actually not even medical school, when you went to school, you know, for me to get into medical school, you needed to have done 3 sciences or science and mathematics. I did both, but you would have biology, chemistry, and physics. And this is ultimately the physics of the math. You know, if you do maths, if you did maths like I did, you had pure maths and applied maths. And applied maths and physics sort of matched together because they gave you problems that were physical that you had to solve, and it's applied mathematics to real life. And this is the applied mathematics of dentistry. And if you can master that, you'll find that your restorations and everything you do lasts a very long time with very few problems. Those sort of veneers falling off, those crowns suddenly becoming pulpal, patients having jaw problems, teeth suddenly becoming widened periodontal ligaments or root canal treatments, you can stop all of that. And not only that, you have longevity treatment. And there's nothing better than that, because then patients thank you for it. Even if they don't understand all the science, they thank you on the basis that their treatment is lasting a long time. Okay, getting on. The phonetics are important. You have to remember when you're doing a full mouth rehabilitation, if you look at if you're doing a lot of these, when you basically reflect all the tissues, you'll find that the anterior teeth in particular, sort of up to 3 to 3, sometimes they're sometimes 4 to 4, are not mid osseous. They're not in the middle of the bone. They're very much towards a buccal. They've almost like either been stuck onto the front with a very thin layer of bone over them, or they're sort of half pressed into the bone. So when you remove these, the bone that you're actually placing implants in is brings the arch in by a good 5 to 7 millimeters at least. So when you're placing these, you'll then have a smaller arch and smaller tongue space, especially at the bottom. So you need to sort of check for phonetics. And, you know, within our consent, you know, which we will go through at the boot camp, and we have consent for all types of treatment. So these are applicable to all types of treatment. And if people want, if they come to the boot camp and they want a consent for aesthetic dentistry, cosmetic dentistry, which are different, anesthetic, sedation, crown and bridge, etc., whatever it might be, perio, we have one for everything. So, you know, we're happy to give access to that. It's not just about implants if you come along, but it's a great way to learn about them. So V sounds are very good. When they say it should touch the dry, wet line of the lower lip, that means a vermilion border. And maxillary incisors edges should be slightly anterior to the dry, wet sound, but F sounds. So usually, I did go over this a little bit, but I'm relating it to the occlusion part of things. So look, if you've got good vertical dimension and you're not encroaching on the neutral zone and there's freeway space, people can actually adapt around a smaller arch. But if that doesn't exist, your F and V sounds go out the window. And the one that mainly comes up, the main problem that people have, is the S sound. That doesn't always manifest just as S sound or whistling, but often they get saliva or spitting because that there isn't that what's known as an anterior embouchure. There isn't that sort of thing with the tongue and the teeth and everything coming together. So that's very important to assess. We discussed a bit of this as a marking the midline and putting the teeth, and this is anterior, posterior spread, but I'm not going to dwell on this too much because I did cover this last time. We did go through this slide last time. I just wanted to touch on something because somebody else asked, and that's why I brought it back to this, about how to assess for the anterior mental loop. And the best way to do this is obviously with a CBCT scan. And OPG, sometimes you can see it's really obvious. It will usually come up as the ID nerve and come upwards as the anterior loop looping back, and then give a branch off from the base towards the incisal nerve. The best way to assess this is a CBCT. So if you find where your mental foramen is, and you'll see it exit out the side of the mandible, if you carry on forward, you will see sort of like, if you look carefully, you will see almost 2 very smaller areas like the ID nerve you'd see in a CBCT carrying on. until they become one. And they're basically the sections of that loop that you're seeing as two separate things coming to a central part. And that's important for you to assess. One of the ways that we do this surgically, because somebody asked, like, if you can't see an X-ray, how do you check? Because you can't see everything on X-ray, which is a wonderful point, and thank you for pointing that out, because I have said in it before, don't rely completely on even a CBCT and X-ray. Okay, I think at best they show 66 or whatever, it's between 60 and 70% of what's actually there. And when you get in there, no matter how well you assess it, things can be different. One of the best ways to do that if you suspect an anterior mental loop is have the surgical skills, A, to find the mental foramen and the mental nerve, and to be able to lift the tissue so you're not damaging that. I tend to use a plastic ball-ended probe, okay, which is flexible and it's not going to push like a rigid metal probe against the tissue in that. Actually insert it into the mental foramen and feel if there's anything anteriorly. And it's all very well saying, well, relying on CT and doing this guided, and that's why I said last time, I don't recommend you do guided. You have to go back to basic principles and check for everything, because it's fine when it goes right, but when it goes wrong, it goes really wrong. And that's basically what you want to watch for, and that's what's important. So, knowing vital structures, knowing where things are, knowing all of the above is very important. One of the other things that I do need to bring to mind, which I know we talk about the mandible, is the maxilla. And one of the students asked about structures around the canine and the upper arch. And I think they mean the canalis sinuosus. So, it's basically a neurovascular bundle that extends from the maxilla coming forward. And now it's very rare to find it in that region above. Usually it's about the canine, sometimes the lateral region tends to be more anterior. But if you look above it, you almost can see this area where it splits, where it comes in above at the top of the bone and then splits into two bits, almost like an arc, way above the apex of the tooth. It's usually about 10 to 11 millimeters from studies above it. And you need to look for that, because if you encroach on that, affect that, the patient will feel numbness and symptoms in the cheek and in the sinus. And sometimes it can be extremely painful. And you don't want to damage that. And this is something that's quite often overlooked and is one of the complications, and it should be considered just as important as the ID nerve, the mental nerve, the anterior loop, and the sinuses. It's just as important. One of the other things that was brought up as well is, like, if you're doing sinus lifts, etc. I know it's not directly related, it's somewhat, but sometimes we don't have that anterior bone to place the angled implants, and where we want to place them so we got an anterior posterior position is further back, and the sinus is in that way, and they're pneumatized, so we have to do bilateral sinus lift before we can place angled implants and even do something like a full mouth rehabilitation. And one of the main things that you need to look out for is blood vessels. Usually you won't see them on an X-ray. Sometimes you can see something that indicates them, and nerves, but usually you see them when you're in there. But the main thing is that you want to see where the septa are, where you want to raise easily, and the membrane. And when you're in there, you can actually see it, because this, if that artery is across the buccal side, the medial part of the sinus, it's very obvious, and it is pulsating, and you can see it as it pulses as much as a facial artery, if you've actually seen that, if you're working in that region and you do that type of work. Okay, so we discussed AP spread and adding an implant. Again, the reason I brought this slide up and I put it back into this is people saying, like, they didn't understand why you placed that implant, why is it so small, etc. That implant is an additional implant. If you're doing something a full mouth rehabilitation and with 4 implants, it's likely you don't have a lot of bone at the back between the surface and the ID canal. So it's basically you having more of a spread. And what it means is not, if you gather everything towards the front because the mental foramen are too forward, then it's like gathering all the legs of a table on one side. So you need to have something else as a posterior support. Okay, so with the maxilla, we didn't go into this as much last time, but we didn't go into it at all. So, marking the midline is a good idea. It allows you to see if you planned accordingly, and there's a way that we measure in front of the sinus, and to see where you're going to place those most posterior implants. Then anterior, you have to see where you have bone. And if you have plenty of bone, like this case, you'll pretty much place them anywhere. So you want to have a decent spread like you have there. In this case, I'd probably place those two anterior implants a little bit further up, so the distance between 4 implants is almost equidistant. In these cases where we don't have good bone in that area where we ideally want to place, and we have to place either side of that, that's where you would consider using 6 implants. You'd also consider placing another 2 implants, like I said before, if you're gathering implants to fall to the front and there's no anterior posterior spread, and you need to add that extra implant. Okay. So here they're using a radio, they're basically using a surgical guide for a radiopaque material. They're using GP here, but so if you propose location of any anatomical structures, do not continue with this treatment modality. Consider moving implants anterior or posterior to prevent harm to the patient. Also remember that AP spread cannot be compromised. I get this, but quite often you don't have that liberty. It's not always as easy. If you can't place them as far back as you need them because the sinus is in the way, then you consider bilateral sinus lifts, or you consider placing them more anteriorly and then having other implants posteriorly. Quite often that whole area is pneumatized and you have no bone there, so you can't actually place the implants where you want them, even posteriorly. And sometimes you have to go beyond the sinus in the opposite side direction. So rather than placing them forward like you would in front of the sinus, you place them backwards around the sinus, behind the sinus. And you can still use a 30-degree multi-unit to straighten that implant, because it's just going 30 degrees the other way. So this also works at the front. If you don't have enough bone at the front, you can't place 2 vertical implants. You can actually place them at an angle forwards. You can then place another 2 implants at an angle in front of the sinus, and you could be placing 2 implants at an angle behind the sinus. Okay, there's nothing wrong with this. You'd obviously be using 3 30 degrees multi-units to correct the angle, or 17s, etc., if the front 2 aren't angled excessively, and this is absolutely fine. We discussed about angulation last time, and not using forces axially in something like this, but you have to remember you have cross arch stabilization. Okay. So to make an occlusal index, coordinate the proper time of the surgery and delivery of the prosthesis of restorative dentist. So that I don't split my surgery and restorative to a prosthodontist. I try and do everything myself. I think if I know where the implants will be placed and I'll be planning for the prosthesis backwards, then the best person to do it is a person that's seeing the overall of it. Using multi-unit abutments, wired internal tape or tapered internal implants, multi-unit drivers, calibrated torque wrench, okay, just to get it there. We've discussed before why we use tapered implants, why we use more aggressive implants, okay. So this is the older way that it used to be done. So what happened was that we used to use a rubber dam to isolate the tissues. We would then have basically the form of a denture. So for example, if I was doing a maxillary full mouth rehabilitation, they've got the existing lower teeth. You'd place your implants, you'd put these cylinders on the you put the multi-units and put these cylinders that screw onto the multi-units. The cylinders will actually form which have screws that screw down, which actually be in the final prosthesis that you put on, because a cylinder was a cap that went over the multi-unit. You screw it on, and you put those on, you get your denture that is supplied by the lab in advance, and you get the aesthetics in terms of, as best you could, the midline, the occlusal plane, and the occlusion. And what you do was make holes so that you accommodate these cylinders, and then fill them with some form of quickset acrylic-like structure, or whatever it may be, so fixed into place, and you got the occlusion as close as you could. You then do a wash underneath. You would then see, and then take a bite, and even if it was exactly on, the lab would then finish that so it is neat, reline the inside so if it gets tissue. Usually we'd have a flat contour to condition the tissue to be flat so that the final prosthesis could be flat, and you could actually have good oral hygiene underneath it. And then they'd bring that into occlusion. So that was the older way of doing it. The newer way of doing it is basically what we do is we do two things. We do a mid-surgery scan. So we scan with using special scan bodies by taking out the front teeth only and do the alveolectomy for the front only. So it means that you have to be really precise, because once you've done that, you can't really change that. You're fixed in it. We then take the posterior teeth out and put all of scan bodies on for implants. There's special scan bodies that you use. And before that, you've done a diagnostic by taking scans of the upper, lower, and the bite. And there's a design. The design is then accommodates where your implants are, and it's a much nicer and much better way of doing it. It's not the fact that it's faster, because sometimes it takes just as much time, but more importantly, it's really accurate. And what you're really trying to achieve by all of this is having an appliance that's passive. You don't want to have a bridge that fits, and a bit like an IKEA unit where you screw one screw and you can't screw it all the way down because you have to screw the other one and slowly screw them down. You should be able to put it on, screw one screw all the way down, and the others will fit accordingly, meaning that you're not tilting it and making it sort of fit around the multi-unit. Because if you do that, it adds an inherent tension, and guess where the tension goes? And if you've got implants that are healing and they are in tension, guess what happens? So that's why the passivity of a prosthesis is so important, particularly in the provisional stage, but also in the final stage. You may not see the consequences of that straight away, but you will see the consequences of that over time, because the tension will produce bone loss in sort of almost like occlusal loading and occlusal trauma. So this is using a surgical guide. So these people using a surgical guide, and I'm not going to go over this too much because I don't use a surgical guide. I don't think you should use a surgical guide for this. There's people that would disagree with me, but I deal with a lot of things that go wrong. Things go wrong for me, trust me, if anybody tells you they don't, then I find a different mentor, because we learn from our mistakes, and sharing our mistakes is the best thing to do, because then other people don't make those mistakes. But I'm not a fan of this. And these lovely videos you see where someone comes in, they dentures, and they just stick a guide on, they drill 4 holes, they insert the implants, they connect the multi-units, and hey, presto, we have full mouth rehabilitation. That's not how it works at all. As you can also see just by the last 4 lectures, it's quite a vast subject. And if you're an implant dentist, does not mean you can do full mouth rehabilitation. You need to learn that specifically and know the ins and outs of it. It's not saying that you can't, you can. And most experienced implant surgeons will have the sort of 22 skill sets, I think, that you need for you to be able to cover all eventualities and complications. So you're not going, oh my God, it's all going terrible, and you can retrieve a case regardless of what's happening. There's a lot of these, they also talk about alveoplasty, etc. But I'm not going to go into that because that's not how we do things. So what basically happens with this is they widen the bony contour, the platform, and what happens is that when we place these implants, especially, for example, when we place the angled implants, you've got a ledge of bone behind it. Quite often, if you see that multi-unit, it doesn't actually fit where it's fitting at the bone. It doesn't fit because the bone is interfering with it. So we use a profiler to make sure that we can actually get those multi-units on there. Once the osteotomies are created, now here they sort of create the osteotomies and they're putting all the implants in one after the other. I don't suggest you do that either. Okay, I'm not going to go through all this because it's not important. It's more important understanding what I'm saying. That what you're trying to achieve is 35 centimeters on each implant. So that involves another skill set of knowing the quality of bone. You also know your quantity and changing your drilling protocol accordingly. Okay. When you're placing the implants, I don't suggest you drill, 4, 5, or 6 osteotomies start placing. What I prefer to do is my first marker is those tilted posterior implants, whether they're upper or lower. So you will usually go with one osteotomy and place one implant on that side, and then go to the other side and place that one. I know that's not fast, etc. It's not about being fast. It's about getting things accurate and doing things properly. Once I know where they are, that gives me the dimension for the front. And sometimes if I place osteotomy and then I know where my front is going to be, I'll check the AP spread. And if it's not working for me, I'll see if I can tilt the implant further, okay, to have less angulation rather than more angulation, to see if I can bring the tip of that implant further back so that I got more space for the straight implant, and see if I can move that further back to get the spread. If that's not happening, then I'll tilt that implant forward too, like I discussed earlier. So, you know, then you put on your healing caps and suture accordingly. When we place the implants on multi-units, we put the healing caps on the multi-unit healing caps, and then we suture, and then we take them off again. And the reason we do this is to make sure that we've got good tissue formation around that multi-unit, rather than it draping over and constantly being over, and you not knowing whether it's in the right position. So, you know, they said again, it's a surgical guide. Again, as I said, I don't use surgical guides, and this is very much the same. Okay, so they've said place 2 implants at the front, 2 implants at the back, and then if you've got sufficient bone in between. As I discussed earlier, I suggest that you plan it in the way that I discussed. To see, you plan in advance, and when you're in there, obviously you don't know until you're actually in there, that you drill a test hole. I think it's called a pin drill with Straumann, but it's a long, very thin drill. I think it's a 1.5 millimeter, or maybe even I think it's a 1.5 mil. Noble has the same drill, and all the implant companies have the same drill. This is a great drill for you to actually plan physically as you're in there, because you planned already, but you want to verify your plan. And the reason being is that when you drill that osteotomy with such a thin drill, it's very easy for you to change that. If you've drilled even a 2.5 mil hole on osteotomy, and then you're trying to change, and that osteotomy you drilled first is right in the middle of where you want to go elsewhere, you've created this much larger hole, and it's not going to go anywhere. Okay, and again, they've placed the multi-units. These are the cylinders I was talking about. The saying about having a 2 mil clearance, that is true. You need to have that. So you verify extended 2 mils outside the gingiva using white registration material. So I'll just go through this very quickly again. So they've placed the cylinders in place, like I've said there. Look, they fit over it. And these are cylinders that are used in the provisional. In the final, what they used to do was use new cylinders that they'd actually bond to a bar, a titanium bar. We don't do that. I don't like that way of doing things, because you can't use titanium to bond titanium to titanium, so ultimately you're creating a weld or a solder, and I don't have confidence in that. So what we insist on, which is considerably more expensive, but that should be incorporated into the fees. We don't really charge extra for doing this. We charge the patient what we pay extra to the lab, so we don't add a fee on top, so we're not doing anything. But we get our cylinders and bar milled out of one solid block, so it's one piece. And you're not going to get flex in that, because long term, what you're looking for is to make sure that your prosthesis is not flexing, because if it's flexing, you're transmitting that force to the implants and things will fail. Anyway, they've placed the cylinders, we don't make a trough hole like this, because they're all gathered in one place. It's usually spaced out. We make individual holes for them to come through. And then we put the structure or Luxa temp or whatever you want to fix the cylinders, do the wash, cut the cylinders off so that we can actually, tops of the cylinders off so that you can actually make it agree with the opposite arch, and take a bite and get the lab to then tidy it up. Digitally works much better, which I've been through. Here, look, you can see them taking the top cylinders. This is simply so that you don't have excess cylinder. You can actually get them to bite up against it. Because if you've got a long cylinder poking out and you're trying to get the bite, it's a bit like having a long scan body and the teeth don't come together. Use rubber dam to protect it. We don't need to do any of this anymore, because we're not using, addition cured silicones and chemicals that drip all over the tissue and everything else. We're using scan bodies. They would put cotton to block the holes, because once you put the acrylic in, if it quite often runs over, it'll block the holes, makes a bit of a mess. And then in this case, they're immediately giving it to the patient, not through lab, and they're using a cold cure to cure it in place. And then on the inside, we're not trained to be technicians. I don't like doing it this way. It's messy and everything else. Why not just send it to the lab? The patient can wait. In our lab, that when we used to do this, would do it within 24 hours. Now we scan, we get a design within 3 or 4 hours, or we print out designs, and we can give the patient something that's very accurate, very aesthetic, and very good almost straight away. And you shouldn't be sitting there having to do all of this. You've got better things to do. You shouldn't be doing the sort of $50 an hour job. You should be doing the more the jobs that, because you've got bigger overheads. You've got bigger things to do. This should be delegated. So after a minimum of 2 months of healing time, all of our should be titrated 8 Newton centimeters. I agree with that. Patients use chlorhexidine mouth rinse only, no brushing or water pick for the first 2 weeks. The patient will use a water pick on a slow speed after that. That's true. We really instill into our patients oral hygiene models in their mouth, etc., months before we do full mouth rehabilitation, and we won't do one unless we know that their oral hygiene is of a standard where implant treatment is allowed. And also we're making sure that they have a long-term aftercare and maintenance, and the maintenance is good, so that's going to last a long time. The patient has to remain in soft diet for 2 months. Not true. Soft diet for about 2 weeks. And then the following 10 weeks, because I wait for 3 months for the integration, which we check, they're on a moderate diet. So it's, things like overboard pasta, noodles, mince, fish. They just can't have like raw vegetables, tough breads, tough steaks, etc., apples, corn and cob, anything that's causing leverage anteriorly. The prosthesis should not be removed in the first 2 months of the healing phase unless there is an absolute need for it. The worst time to fiddle around with implants is 2 to 4 weeks, because the osseointegration goes up and then dips down before it goes back up again. And that period in between, if you fiddle with temporaries or anything else, you could cause movements of the implant and formation of granulation tissue and the lack of osseointegration. I prescribe an antibiotic regimen and pain medications as needed. I'll come back to that. And follow up 1 week. We follow up with 1 week. We follow up then again in 1 month from surgery, and then we follow up again 3 months from surgery. That's important. You just don't want to see a week later then let them be free. You want to make sure that everything goes in the right way. One of the things with the medication, so this is the final thing for tonight before we come to an end, is what medications do we prescribe? Post-operatively, generally for us, we tend to prescribe for pain relief Panadine 4 if they can have it, and that's fine. If not, and they can have it, we like because an analgesic, anti-inflammatory, non-steroidal anti-inflammatory drug. We tend to do combination of paracetamol and ibuprofen. You get over the counter. There's trade names like Neuromol or Maxigesic. If the pain is severe, then we prescribe endone. But we're very careful about that. It's controllable. You need to watch what you're doing with that, because if you're prescribing it here, there, and everywhere, you'll come into hot water. So you need to be careful of that. We also prescribe for patients where there'd be large alveolectomy of bone work, some steroids, and you have a window of about 3-4 days within surgeries to stop that excessive swelling. And we prescribe antibiotics. We also prescribe diazepam. That's not only for helping patients to sleep, and that does help with that, but also for patients to stop muscle spasms. And that quite often is the basis of a lot of their discomfort. To be honest, when I do full mouth rehabilitations, and we do a lot of them, I mean, for example, this week where we've done 5 arches, it's patients rarely complain of pain. They get swelling and bruising, which is unsightly with all of them, all of that, but they don't get pain. They don't tend to get a lot of pain. You've had surgery, so let's be honest, it's going to be a bit tender, but they don't get spontaneous pain. And a lot of them report that they're feeling a lot better. They feel like they're not as diseased and things are much better. Not maybe immediately because they're on drugs or anything else, but not very shortly afterwards. And that's not surprising, because a lot of these cases, especially the ones I have with disease, there, once you remove the disease, and we're very careful at making sure we irrigate, use piezo to get rid of all granulation tissue, abscesses, infection. So we've got nice clean bone, even in sockets where we're not placing, because that can travel. Patients obviously going to feel better. They've got chronic low-grade sepsis. It's like having infection that's just dripping into your blood. It's almost that it's low-grade septicemia, and that's chronic, and therefore it's not detected. The patient doesn't have immediate acute symptoms, and therefore, you know, they're not looking for help and not treated, but that's basically what it is. And, you know, most of them report that they feel a hell of a lot better. Okay, I'm just going to stop sharing the screen. We'll get to it. If any of you have questions, please ask now. I'm happy to answer any questions. If you haven't, you know, as I said, this will be, we will be continuing webinars, but this will last for a little while. And we're coming up to Christmas. I wish everybody a Merry Christmas and Happy New Year after all the events that have occurred this year. Please do like and share our Instagram and our Facebook, and more importantly, sign up to the bootcamp. Even if you're placing implants, come and review your protocol, your processes, your systems. You know, if you want to bring a staff member, they may not be a dentist, but ideally it'd be great to bring a dentist. If you're a principal and you're interested, even if you don't want to place the implants yourself, send your associates or bring an associate. You know, that's the whole point of that buddy system. We're having two for the same price as one person. I look forward to seeing you, hopefully, at the boot camp. If any of you are interested, there's been fewer inquiries about the actual accredited courses, because you want to get a formal qualification and you will start learning in a proper way, in a graded way, then the certification diploma and MSc are open for next year, for the middle of next year. So please give us a call, send us an email, drop us a line. I wish you all the best and take care, and I shall speak to you soon. Bye-bye now.